Hello, everyone. Thank you for joining today. I see we're still having a few people join. I'll go ahead and get started though. Just a couple housekeeping items and just some introductions. This is session 1 of 2 for our nursing home TikTok series. I'm not sure, for those of you who are familiar with the TikTok app, I kind of stole the little phrase from it. So they are 1 month apart. The next session is actually on October 19th, so about a month from now, and we'll be at the same time, 3 p.m. Mountain Daylight Time. And the second session will be on CRM, which is Community Resiliency Model, and that'll be introduced by my colleague Caitlin Conway, who's also on. And so if it's not on your calendar, you can still register for that upcoming webinar on our website. Also, just a little plug in there for tribal nursing homes. There's also a CMS resource called Unite, and if you want to know more on that, we can definitely get you more information on it. But they have a lot of education, webinars, tools, best practices, and whatnot for tribal nursing homes. And also, last year, Telegen, which is another QIO similar to what Mountain Pacific is, created a document called Resources to Support Trauma-Informed Care for Persons in Post-Acute and Long-Term Care Settings. Excuse me, and that is also available online, and I will put those links into chat or towards the end of the webinar. So you will be on mute towards the end when we will have some open discussion. If you do want to speak up, just let me know, just put it into the chat box. And our moderator, she can promote you to a panelist. You're able to speak. Otherwise, any questions, comments, or anything like that, feel free to use the chat function. So with that, I'll get going. So just a couple learning objectives. I just wanted to review some of the recent regulations that CMS had put in, define some key terms and concepts related to trauma-informed care, understand what trauma-informed care is and how COVID-19 affects that process. Also understand some basic findings in trauma research, and then the link between trauma and then chronic disease, and just briefly touch on protective factors that build resilience, because our next session will really focus on some resiliency pieces. So, and again, anytime any have questions or anything, just please put them in chat. So effective last year, CMS, I think it was actually November 28th that it went into effect. CMS put in regulations for long-term care facilities to assess and address trauma and behavioral health. The guidance that CMS issued is to follow the Substance Abuse and Mental Health Services, otherwise known as SAMHSA. And they refer to the document called Concept of Trauma and Guidance for a Trauma-Informed Approach. And that is also available online for free. And I, again, will put these resources in there unless one of my colleagues feel free to share these resources. So according to SAMHSA, there's 10 domains of implementation for a trauma-informed approach, and you can review those within that document. One of the main ones is governance and leadership. And so really it takes a team to implement trauma-informed care. And the biggest part is leadership buy-in. So it's very important that your leadership understand and also support it. SAMHSA, which like CMS is part of the US Department of Health and Human Services, has developed a concept of trauma based on the 3 E's. And that stands for event, experience of event, and effect. So per SAMHSA, individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So with that being said, when we think about how we provide care holistically, it's super important that we consider historical trauma and past trauma. Also, besides stating the obvious to how important it is, to have a trauma-informed care approach for your residents and patients. There's also data on how it can help improve staff retention and recruitment, and not to mention eliminate patient safety incidences and staff safety incidences, which benefits more than just facility, but also helps with better continuity of care as well. So those of you who are familiar with culture of safety or just culture, a lot of these really marry well together with trauma-informed care approach and just culture. So like I said, this last November, CMS did complete the final stage of rolling out the requirements to implement these trauma-informed care regulations and are now in effect. They are under the FTAG, F699, which is trauma-informed care, which is a quality of care FTAG, F659, which is comprehensive care plans, qualified persons, F741, I know some of this is a little dry, but just wanted to put those FTAGs out there so you can reference them. Sufficient competent staff behavioral health needs, F949, behavioral health training, as well as other tags. So there's also a F742, treatment service for mental psychosocial concerns, and F743, no pattern of behavioral difficulties unless unavoidable. So these ones, I just put in some examples of what surveyors might use to determine if residents receive necessary mental or behavioral health care services. So examples, did the facility provide appropriate treatment services to correct assess problem for resident? So, and then this tells you which FTAG they're going to cite. And I'm not going to go too deep into this because I think the bulk of this is really understanding what trauma-informed care is. So we know how hard you as nursing home staff have to meet the needs for your residents and for your facility. And these new regulations really are not meant to put yet another burden on your shoulders, but to provide a name to the holistic aspect in your daily cares. You work with your residents, you know them, the same residents daily. And so their family, their friends will ask you, how are they doing? Because they know you pay attention to them. So thank you for what you do. Really, honestly, thank you so much. And as caregivers, it's okay to ask for help and to need a break or talk about your feelings as well. So something that's helpful to have is a list of local resources started, such as list of local mental health, behavioral health resources. There's been a lot of work being done with telemedicine, so those resources are available. Also with tribal, cultural, spiritual resources and other medical resources that anyone can have access to. A lot of people may be familiar with EAP, Employee Assistance Program, which is free for employees. I also want to note that trauma is a painful topic, and some of us may recognize ourselves, our loved ones, community members as people we see in some of the symptoms for trauma. So if any of these topics we talk about today cause feelings of disturbance or just uncomfortableness, please seek out, ask for help. There are a lot of people around you that you can turn to. And so right now, even though we have to physically distance, that doesn't mean that we have to socially isolate ourselves. So let's talk about the definition of trauma. So trauma is the real or perceived threat to life or safety of a loved one. The experience causes an overwhelming sense of terror, horror, helplessness, and fears. And like I said, SAMHSA has the 3 E's of trauma, which are event, experience of event, and effect. Events are actual or extreme threat of physical or psychological harm, such as natural disasters, all the forest fires we have going on, violence, and so on. These may occur as single occurrence or repeatedly over time. The second E is experience of these events or circumstances, helps to determine whether it is a traumatic event or not. It is how that individual who experiences this, how they assign meaning to and how it disrupts them physically or psychologically, and it contributes to whether or not that individual is perceived as traumatic. And each person can have that same experience and perceive it very differently. So to assume that just because you think something is traumatic may not be traumatic to the person next to you. And so the third E is effect. The effect that what trauma that individual experienced may occur immediately, or at times may have a delayed onset. There are times when the person may not recognize they have physical or emotional responses to a trauma, but only discovered through an inability to cope with normal stressors and strains from daily living. And maybe may dysregulate their emotions. So thus we have those behavior changes in people. So SAMHSA, they have the 4 R's in which to implement this trauma-informed approach, which are realization, recognize, respond, and resist re-traumatization. In realization, you have a basic understanding of trauma and how it can affect us. This then leads to recognizing the signs of trauma, and trauma screening and assessment help to do this. And that helps to really lay that groundwork for workforce development, employee assistance, and modify supervision practices. And so the third R is response, and this is applying the principles of a trauma-informed approach to all areas. And lastly, the fourth R is resist re-traumatization of your staff and residents, your patients, community, reducing or eliminating practices that can cause triggers of painful memories or actions that re-traumatize. This helps to enforce healing and resilience in those people. So a lot of you may have heard of this, the ACE study. It was a groundbreaking study back in 95 to 97, and Drs. Vincent Folletti and Dr. Robert Anda ran the study from CDC. And what they did is they surveyed mostly white, mostly middle-class patients about whether or not they had experienced any of the 10 types of adverse childhood experiences, or ACEs. So to put this into perspective, the website aces2high.com coins the explanation as to explain a person's risk for chronic disease. Think of this, the ACE score, as a cholesterol score for your childhood toxic stress. And you get 1 point for each type of trauma. So higher the score, the higher your risk of health and social problems. And there's 10 types of childhood trauma measured in the ACE study. 5 are personal: physical abuse, verbal abuse, sexual abuse, physical neglect, and emotional neglect. And then 5 are related to other family members: a parent who is an alcoholic, a mother who is a victim of domestic violence, a family member in jail, a family member diagnosed with a mental illness, and then the disappearance of a parent through divorce, death, or abandonment. And so each of those traumas count as 1. And you can do that score yourself. You can go to aces2high.com. But I do also put that flag of warning, just that it's a score and it's not a destiny. So what this statement means, this dose-response relationship, is that as the dose gets bigger, as in the amount of doses of trauma in one's lifetime, the response gets bigger. So in other words, with increased number of ACEs, the risks of developing negative health outcomes is multiplied, and as you can see here. And the biggest point of this slide is not a point, not that it's statistics, but these are people, human lives. These are families, children, fathers, mothers, aunts, and our communities we grow, work, and invest in. So remember again, that it's a score and it's not a destiny. So when we talk about types of trauma, there's acute, chronic, complex, and historical. Most times we focus on a person's subjective or perceived experience of a situation, but research and clinical experience have shown that the nature of the underlying event or events can have a very powerful influence on a person and how the way they respond to that experience. Some of the many ways you'll hear trauma talked about in this way are acute, and that's a single event. Examples include violent incidences, accidents, severe weather alerts, sudden loss of a loved one. Chronic, this is exposure to multiple different events, which can be examples of a car wreck or loss of a loved one and community violence, or can be repeated exposure to the same type of event, such as ongoing neglect, parental mental illness, substance abuse, or ongoing physical or sexual abuse. Complex trauma, this is responses to repeated events, as with chronic trauma, but also including a wide-ranging developmental effect that compound trauma responses, and this makes it more complicated to treat. Historical trauma, this is responses to mass historical events or genocidal or ethnocidal intent, which means to destroy a whole people, such as a tribe or race, or the Holocaust. Historical trauma is experienced by all or most members of a group, but also remember that different members of a group may experience and be impacted by historical trauma differently. And just to put a reminder in there of our just recent 19th year anniversary of 9/11. Also to note that most people use the term intergenerational trauma interchangeably with historical trauma, in which intergenerational is defined as trauma experience responses that are transmitted from one generation to the next, including traumas related to mass historical oppression, as well as traumas experienced on the individual level and passed down from parents to children. So essentially, it's basically taking that trauma backpack and putting it on the back of your child. So as healthcare providers, as caregivers, and just being a human being, when we hear someone say to us, when we are having a difficult time with something or not being able to cope, to pull yourselves up by your bootstraps, or other slang sayings, we have immediately set the tone that we don't care and that we don't understand what they've gone through and cause that person harmful emotional discord. Like I had mentioned, the fourth R that SAMHSA had defined, to resist re-traumatization, means that we have to do our part by screening, prevent labeling behavior, or failing to acknowledge that a staff member is getting burnt out, otherwise known as compassion fatigue. As a lot of patients, residents, and community members have to transition into a new setting or go through a life-altering situation, whether they have had a mental deficiency or not. That process can be a trigger to re-traumatize and unfortunately cause physical, emotional, and spiritual harm. And we, as healthcare providers or caregivers, interact with them during this transition period to ensure that how we react to behaviors, quote unquote behaviors, a lot of us have learned to call it that in long-term care, that can develop meaningful and trusted relationship. We need to be mindful of how we treat our residents. Think about how you currently address privacy, taking medications, providing choices, and involve them with their daily cares. Do you feel that what we have talked about so far aligns with being sensitive and reduce triggers for your residents? When a resident does voice a concern or displays an emotional or physical response that may be out of the ordinary for them, how do you determine whether this may be a sign that they need to go to the toilet, or maybe that they have been triggered and this is causing them to have traumatic stress? Working with your team to educate and strategize how you may want to change your current policy and procedures, change your orientation to include trauma-informed culture, and wish to see within your organization other forms of trauma-informed care. Also in the process, you may find that learning about trauma and understanding it may cause you as a healthcare provider or worker to become traumatized or to trigger you. Burnout, it's a very real phenomenon. Do you know your own cues when you become emotionally fatigued or compassion fatigued? What are your triggers? Knowing yourself, knowing when to say, I've had enough. What self-care do you have? Do you have a way to mitigate or de-escalate yourself? How about your organization? Excuse me. Is there support for how to respond to stressors or trauma? Some organizations, again, when I talked about the EAP, the Employee Assistance Program, can readily be available to you, and it's discreet and free, and it's highly encouraged. So does your organization have this? Is there posters up? Just going to do a quick check of the chat here. See some links. Thank you, Caitlin, for putting those up there. And Barbara, I will get to that, that question for sure. And yes, I will be sharing my slides. So when we talk about trauma events in residence, how can nursing home staff mitigate or assess these areas? Adverse child experiences, or ACEs, is simply putting, like I said, like a cholesterol score towards your childhood traumatic experiences, except to help in that dose of trauma in one's lifetime. So it's a score, again, not a destiny. So I just want to make that very clear, because sometimes when people find out their ACE score, it's a big trigger for them. Knowing what the ACE score is for yourself and for your residents, it does help to see that person as a whole and understand what happened to them, not what's wrong with them. Intimate partner violence or family abuse is one of the questions within the ACE. But as caregivers to residents who may have had this experience in their lifetime, think about how they react when you have people coming at you, undressing you, telling you where you can and can't be, and so on. They may not have their bearings about them, but that internal physical response, it's a big indicator for you to see if what or how you may be doing something has triggered them. There's also a lot of senior war vets, and I would bet most have never had an accurate diagnosis of PTSD or post-traumatic stress disorder, which yes, can be from war, but it can also be from their lifestyle they had, living in poverty, abuse, and so on. So when we better understand our residents, and for a minute, think about what they must be going through in their head when they hear buzzing sounds, alarms, people shouting, doors slamming, or med carts doors shutting, how these sounds may be causing them to be internally reverted back in their life when they were scared, severely threatened, or just scared. So being mindful of these types of things helps us to be better caregivers. Even now during the pandemic, how they are suddenly isolated from their friends down the hall, from their loved ones coming to see them, or seeing masks instead of smiles at them, it's confusing and it's traumatizing. So who heard the term, it's called transfer trauma. It's a term that to describe the stress that a person with dementia may experience when changing living environments, and is more commonly seen in the person with early stage dementia, and when one is moving into a facility from their lifelong home or community. So again, as caregivers, being able to recognize signs such as depression after admission, anxiety, resisting care, or other behaviors that disturb their quote unquote normal way of life prior to functioning, coming into their new home, is important to intervene early and allow that person to do things such as continue to know their purpose and to contribute however they used to. And it can be as simple as allowing to clean their own area, tend to a community garden, or help to fold laundry, and so on. So when we look at this slide, we think about how does this relate to also with COVID and social isolation. When we see those biological effects from trauma, physiological or psychological, spiritual, and then social behavioral. Think about how all of this and how we provide care holistically for our residents. So this is a very interesting topic, and this is probably one of the newer pieces of evidence that they've done on trauma. So this is toxic stress in the brain. So the constant activation of our stress responses, and this is often called to as toxic stress or traumatic stress, can overwhelm the brain. And so we as human beings have heard that our fight, flight, or freeze response, we're never supposed to be in that for more than 15 minutes. That's just kind of how our body is set up. But when you're in a constant state of this, it affects the way that we function, the way our brains function. So there's 3 key areas of the brain that are affected by repeated exposure to traumatic stress. So the amygdala, the medial prefrontal cortex, and then the hippocampus. So each of these 3 areas of the brain, they're still developing in children, and exposure to trauma and toxic stress can prevent them from developing properly. So as adults, when we've already developed these things, we have to keep that mindful of what happened to them, not what's wrong with them. So the amygdala is responsible for our reactions to potential dangers in our environment. It's important for all of us to be highly attuned to people, places, and things that pose dangers to us. So for example, when a child is hyper-attuned in this way, they can have trouble paying attention or being open to new experiences, such as going to new places or meeting new people. So now put these perspectives into the older adult brain, something that they already went through as a child. The medial prefrontal cortex, it's closely involved in the amygdala's functioning, and it contributes to the ability to learn that circumstances, people, or places that were at one time dangerous are no longer dangerous. Connections between the amygdala and the medial prefrontal cortex can get disrupted by trauma. So the ability to judge that a current situation is safe has been reduced. Children whose brain development is affected in this way are often easily triggered by reminders of past dangers or traumas, even when there's no danger present. The hippocampus, this plays an important role in memory, including the way memories are stored, the way memories are retrieved, and the ability to differentiate between past memories and present realities. Brain imaging in people who have experienced childhood trauma has shown reduced size in the hippocampus. Children who live with trauma exposures and toxic stress often have a hard time learning, retaining information, including information that helps us determine whether or not a current situation is dangerous or not. So thinking about all of this, the biological response to trauma, that it's not just in your head, that it's actually physically changing the way our body works. So we talk about the 6 principles of trauma-informed care, and this is according to SAMHSA, again, Substance Abuse and Mental Health Services Administration. So they came up with these 6 key principles. And so safety, this prevents violence across the lifespan and creates safe physical environments and creates areas that are calm and comfortable. It also promotes feeling of safety in interpersonal interactions, such as by encouraging staff to, 1, ask open-ended questions and be sensitive when they need to interrupt for an elder's activity to provide personal or medical care. And then we have trustworthiness and transparency. This fosters positive relationships among people and provides clear and consistent information. Then we move on to peer support. These are integral to the organizational and service delivery approach and are understood as a key vehicle for building trust, establishing safety, and empowerment. It allows for the residents to share their stories and for us as providers or caregivers to do things such as provide a means to stay connected to their family, friends, and community in a safe way. And then collaboration and mutuality promotes involvement of residents and partnerships among all. So decisions are made together and their care is based off what is important to them as individuals, instead of making them adjust to what the organization feels is appropriate for their care and treatment. And then empowerment, voice, and choice. This ensures opportunities for growth are available and for all, and that the capabilities are recognized. This builds on what clients, staff, and other communities have to offer, rather than responding to perceived deficits. And then last, cultural, historical, and gender. It's moving past cultural stereotypes and biases. It offers culturally responsive services, leverages the healing value of traditional cultural connections, and recognizes and addresses historical trauma. Some of the ways to be more inclusive of your diversity is serving various types of healthy food that is representative of cultures, and doing cultural and traditional activities. Also, it's important to recognize and honor those that may have served in the military and our veterans. So when our body is regularly activated and stays activated, like I was talking about the flight, fight, or freeze, instead of fading after your natural response, the brain and body remains on a constant alert most of the time. And it's very, very toxic to our development. And this is unhealthy stress, and it changes the way our brains as people, how we develop and how your brain functions. And it takes a toll on our bodies, and it leads to attempts to cope with that stress, which is usually harmful. Understanding this and finding ways to mitigate or reduce stress responses will help our bodies and minds to stay in control when a stressful situation occurs. Ways such as eating healthy, regular exercise, trying relaxation techniques like deep breathing, yoga, or getting a massage, taking time for things you enjoy like fishing, reading a book, crafts, and so on. Also having healthy relationships and people in your life you trust and you can depend on or help you. Another little bit of self-care is not watching too much news. I found that to be very helpful for myself right now. Our bodies were not designed to stay in a constant fight, flight, or freeze mode. And so when it does, there are increased risks such as increase in anxiety, depression, digestive problems, headaches, heart disease, sleep problems, weight gain, or problem with memory and concentration. And that's just some very like touch of the base responses to toxic stress. So now when we move into how does trauma cause chronic disease, when we have this constant state of traumatic stress and it's been unresolved and moves into adulthood, now those childhood experiences have a direct response on our bodies as adults. Also, as adults, we may have experienced other traumatic events, such as losing a job, losing a spouse or loved one, a medical diagnosis, and so on. So there's a few ways that these events have effect on our body. Either we are using unhealthy coping mechanisms, such as smoking, drinking, drug use, illicit drug use, overeating, and so on to deal with these experiences. Or our body can chemically and physically try to adapt with increased stressors and wear it down, resulting in chronic diseases states like heart disease or diabetes or high blood pressure. So there's a lot more research now on how our bodies react biologically to the stimulus from those fight or flight responses. When adrenaline has a constant activation in our bodies, it produces inflammation, which has been shown to cause heart disease and some autoimmune diseases. So stress and toxic stress can literally be killing us. So with this, as we've talked about before, how can we change our conversations with our patients, our family, our friends, and not say what is wrong with you, but what happened to you? So in order to develop that relationship we desire, we have to gain trust from that individual or individuals by showing compassion, respect, and holding space. And for those of you who are maybe familiar with that term, maybe you want to type into chat what holding space means to you. So when we talk about resilience, what is resilience? A positive adaptive response in the face of significant adversity. What a meaning. This really, it really resonates, especially to me right now. I think in all of the wake and everything going on, I think more and more it's important for us to have resilience in ourselves. And I think Marcy, did you raise your hand? Maybe Mary, if you want to promote Marcy to panelist, she might want to speak up. Sorry, I'm not watching chat here. So this resiliency can also be developed and promoted. And so a key component of resilience is being able to reach out to others for support, which doesn't necessarily mean only to professionals, but our family, our friends, and again, holding that space for each other. And so holding space, when someone holds space for me, what does that mean for me? To me, that means I'm able to speak freely and I can express my emotion and not feel judged. I think that's a big piece, is that when we have a true emotional response, a lot of times we'll try and inhibit not crying. We don't want to cry in front of somebody or show our true emotion. A lot of people, you know, historically, I think we have shown that showing emotion shows a sense of weakness, but I think it's quite the opposite. I think that means that you're a human being. So again, protective factors, relationships. So when we have good relationships, good solid relationships, people that we can trust, people that we can show emotion to, having good friends, having a good mentor, providing that support and empathy to each other. Being empathetic or being sympathetic is two different things. And then having trust in close friends. So being able to have that ability for someone to come to you or for you to go to them, you know, whether it's just a conversation or maybe it's something at work. Maybe you're unfamiliar with a medication, or maybe you're just having a bad day and you need to tell somebody. So it's just, as human beings, we just need to be kinder and being a little bit more sensitive to what everybody's going through right now, and especially our residents. So with that, I do have some discussion. I did not put a case study because kind of forgot in a webinar, you all are not able to take yourself off mute. So again, if you do want to discuss anything, you can just put that into chat. And what we can do is we can promote you to panelists. And what that means is that you'll just be able to unmute yourself and speak. So let's see. Renee, yes, I'll be sharing my slides. I think Caitlin answered your question regarding camera. Barbara specifically has trauma-informed care and behavioral health aspects of phase 3 regs changed since they were last published? And is CMS now enforcing all phase 3 aspects of the regulations? So let's see. I am not familiar, but let me see. I believe, yep, Marcy, you are promoted to panelist, so you can take yourself off mute. So if you have any feedback for that question.
Hi, Alana. Well, just in regards to raising my hand during the resiliency quote, I was just trying to type into chat and hit the wrong button, but as long as you promoted me to panelist, I was just agreeing with you that that is a really powerful statement, and I really like that. I've never seen that before. So in regards to the question, I can't see the question. So is that in chat? And you might also want to promote Lisa Johnson. She might have some comments on that as well, but can you either repeat the question, or was that in Q&A?
Yeah, so the question was specifically, Barbara, you are now a panelist, so you are able to unmute yourself too, and if you need to clarify your question at all. And Eliza, you are now able to speak as well. So it said specifically, has trauma-informed care and the behavioral health aspects of the phase 3 regs changed since they were last published? And is CMS now enforcing all phase 3 aspects of the regulations? And Lisa said she's researching right now like crazy. So I think if there's anybody that has any input on that, as far as I know, I have not seen any changes. Yeah, she says, I believe most aspects are in effect, but she will confirm. She'll do some, okay, Barbara, you're on the phone, all right. Some research on that, but from what I was seeing on the CMS website, I haven't seen any changes. Hopefully that answers your question. So this is a very general question, and I guess more so just to kind of gauge, because another project that my colleague Caitlin Conway and I work on is a trauma-informed care project. And we had the opportunity before COVID, of course, we would go to organizations and provide education to staff. It would range from front desk to, it was always in either a clinic or hospital, to MDs. You know, there were some EMTs in there, there were housekeepers. So it was a big variation in staff. And I was truly surprised when I started talking about trauma. A lot of clinicians even thought that I was speaking about trauma in an emergency room, that it was really not a very well-known topic. So my question, what does trauma mean to you? And you can either type it in the chat box, or if you want to speak up, we're more than happy to promote you as a panelist as well. Any input? How about, what additional resources does your organization need to implement and sustain a trauma-informed approach? Sorry, I have flies everywhere, there's smoke everywhere. Troubles. In terms of implementation, or maybe support for your leadership to understand and encourage a trauma-informed care approach. Policy examples, orientation, competencies, what do you feel that you need to be able to implement trauma-informed care into your organization? I see Amber had put in, I think loads of education is needed for the people who work directly with patients. Yes. And when we talked about trauma-informed care with the domains, the implementation domains, according to SAMHSA, again, you know, it's setting that governance and leadership that they have this, that they support it. And then having a team doing an organization assessment. Amber says, I think it's something that a lot of people have very little understanding of how childhood trauma can affect adult. You are so right, Amber. And then Lisa just said, phase 3 conditions of participation regulations. I just asked our head of state survey. He responded that he hasn't heard either way. He will ask CMS this week. So we will get back to you all on that response. So I see some people in there. How about Marcy? What do you feel are some considerations for additional resources that maybe you're hearing from nursing homes that are needed?
Well, I was just thinking that, Alana, I'm not real sure. You know, we're doing obviously a lot virtually now due to COVID. So I would be interested in having folks maybe even type into chat, what are some of the things that they need help with? You know, I know that we are working on updating our website. We're doing this trauma-informed care series, and that was a question I had. What is working? What would be something that Mountain Pacific could help you with in your facility in terms of trauma-informed care?
Education for the public, families, and so on, so they understand the necessity for isolation and can help find creative ways to stay connected, is what Lisa had typed into chat. Yeah.
So just, it sounds like that education piece is really important and a big component of this. So some things maybe we can work on our end. Yep.
And from a patient family advisory perspective, Caitlin, do you feel that there's any considerations from a patient family perspective that we can maybe take and maybe change some of the ways that we're doing trauma-informed care approaches?
I think you're absolutely onto something there, Alana. I think that really changing that lens that we look through things, right? That trauma-informed lens, but also from the patient side of a trauma-informed lens. Really, we're adding two things to that. And so it's just a whole nother dynamic and really shifting. So I absolutely think we can change some of the conversations, our treatment, our interactions, even the way we're portraying these trainings. I absolutely, you're right. We'll bring patient family advisors into this as well.
Has anybody used any type of patient family advisory councils within their organizations to do, I mean, regardless of trauma-informed care, have any of you used your patient or family to get feedback on what you're doing and how well you're doing it? I think having that patient voice, resident voice, or family voice is so imperative, so that, you know, we work really hard as caregivers, as providers, and we really don't want to do something that really is not of benefit. And we all have our heart in the right spot, but we want to make sure that we're doing it correctly and we're hearing them. How about, what are some considerations to have for creating a trauma-informed approach so you don't silo the approach or implement this in a vacuum? You know, I had mentioned how a just culture and a culture of safety really go hand in hand with implementing a trauma-informed care in an organization. And I worked with facilities. I'm just culture certified as well. And I think some of the elements for a culture of safety and accountability, you know, I think some people feel that trauma-informed care approaches is soft, and that it gives people an excuse or an out and not being accountable towards something. When you put the two together, it really creates a lens that is unique and kind of makes you sit back in your chair and go, whew, I didn't think about that. Lisa says, I think COVID is bringing a whole new kind of trauma to our nursing homes. I would 120% agree with that. I think everyone. And then Caitlin said, if anyone would like additional training, tools, resources, etc., and effectively bringing the patient, family, and caregiver voice into your work, don't hesitate to reach out to her, and her email is kconway@mpqhf.org. And Paula mentioned, in working with employees who have had trauma, we could use some approaches on balancing our responses to them, but also getting the job done. The pull yourself up by your bootstraps approach is not recommended and does not always work. I totally agree. Yep. And this Wednesday, we also have another webinar, and it's Jennifer Busher from Show-Dare Children's Hospital. And even though it's a children's hospital, they've implemented a structured model for doing a trauma-informed care approach within their organization. And she's presenting on that on Wednesday. If any of you want to, you're more than welcome to join that webinar as well on Wednesday. But when I had an opportunity to visit with her, she was talking about how it not only changed the culture of their trauma-informed care, but just kind of the organic things that happened is that it improved their patient safety incidences. They noticed a decrease in patient safety incidences and staff safety incidences, increased morale, increased recruitment and retention in their organization. So, you know, it's a lot of work, and it takes a team. It really does take a team. So to put this all on one person's shoulders is unrealistic. I can say that for sure. And I see Caitlin did put the webinar into the chat box for those of you who are interested in learning more about that. She's also going to go through beyond what the sanctuary model is. So it's just not just about the sanctuary model. And then Lisa said, at Paula, for those employees who have experienced trauma, can you give them a quote, timeout or swap with another staff is something someone is triggering? Right. How about, does your facility or organization currently have a trauma-informed care policy? And if you do, are you willing to share that with others? Because our SAMHSA does have a trauma-informed care policy template, and I definitely have started a little repository of policy examples beyond trauma-informed care. But so if any of you are interested in having some example policies, I'm more than happy to share them. Amber said, that's so important. I think people forget that the patients aren't the only ones who have experienced trauma. Yes. Yep. And then on the 23rd, I have to, yep, next Wednesday, former colleague of mine, Dr. Tammy Jolly Trottier, is presenting on compassion fatigue. So it's another one if any of you are interested. And Barbara, please email to Lisa and she can forward to your team. You bet, I will do that. All right. And then Lisa, maybe taking some time to discuss one-on-one with the employee what is traumatizing them and brainstorming ways to prevent re-trauma. All right. Any final questions, thoughts? No? If not,
Hey, Alana, this is just Marcy. I was just going to encourage everybody to, complete the evaluation. I'm sure there's going to be a post-evaluation. So just let us know, any ideas, thoughts, again, on ways that, we can be helpful and help you out within your facility. That's another way to document that and get that to us.
Yeah. Yep, Barbara, you sure can. You just have to unmute yourself. You're able to unmute yourself, or else I can unmute you. If you're able to. *6. There you go. You should be able to speak now, Barbara. Huh. We don't hear you. Can anybody else hear Barbara? Nope.
No, we can't hear her.
Shoot. Maybe you want to, I don't want you to Google it, Barbara. If you want to type it in chat, you can do that too. Or you can email me too. I can, or give me a call. I think, I did not put my phone number on there. And this is my work number. If you do have a question, you can call me as well. All right, any other final questions, thoughts? Anybody else from Mountain Pacific have anything they want to share? No? So the next session again is October 19th, and again, it's at 3 p.m. If you registered for the webinar today, it should automatically go on your calendar. Am I correct, Mary? I'm pretty sure.
I'm pretty sure. I think you're right, Alana. Yep.
Yes. Okay. Yep. All right. Any other questions? You can either email again or give me a shout. So thank you again for your time today, and I hope you have a great rest of your day.
Thanks, everyone. Great job.
Thank you.